Assalamu alaikum. Today we will just today we will discuss this antepartum hemorrhage. So can anyone just chalk out what are different causes of antepartum hemorrhage? Yes, anyone please?
Placenta previa,
Okay, very good. Placenta previa. Okay, what else?
placental abruption,
Very good. Placental abruption. What else?
So, scar rupture.
Scar rupture. Okay.
Rupture of the scar.
Okay. What else? Can we just classify broadly?
uterus atony,
No, uterus atony will be postpartum. Okay, uterus atony will be postpartum. So antepartum, what will be the causes for antepartum? Just a second, please. So many windows are open. Apologies. Can we just broadly divide like how to for our understanding? Can we just divide categories of antepartum hemorrhage? Actually, if remember one thing, if someone asks you, or if you are thinking about any cause of for anything, if you just start in a haphazard way, maybe you are able to tell everything, but there is most likely that you will forget some of the points. So you can in some of the books it is written classify or moth die. Okay, so it is better if you are able to, if you can classify. Okay, so if you want to classify antepartum hemorrhage or anything, first of all you can say that it is maybe pregnancy related bleeding. Okay, but because what is antepartum hemorrhage? Antepartum hemorrhage is, can anyone tell what is antepartum hemorrhage? Because it is bleeding before the delivery of the baby. Am I right? In the last trimester, if it is occurring before it, what do you call it? Because I myself maybe not be very clear in defining it, but just to simplify it, it may be causes, maybe patient related. Okay. Or patient has any bleeding disorder. Okay, so even if you are thinking about or telling about bleeding, you should be thinking that it may be related to any other cause. Patient may have some bleeding or coagulation abnormality. Patient may have some medical disease which is causing bleeding. Okay, so you have to think this thing. Another thing, like specifically if you are just concentrating on obstetric causes, so one, you can divide it in by painless and painful. Am I right? So this may be a hint in when they are trying to chalk out the cause. So what will be the painless causes? Placenta previa. Okay, while what will be the painful causes of antepartum hemorrhage?
abruption,
Abruption. What else? What about rupture? Uterine rupture. Yes, can you hear me? Because I was, I think, disconnected. So can you hear me now?
Yes.
Okay. So maybe you try and rupture. Okay. Can anyone just correct me that if we have, how can we define antepartum hemorrhage? Maybe we will find a definition here. As a bleeding in or on into genital tract occurring from 24 weeks of pregnancy. So I was right. And prior to the birth of the baby. Okay. The most common, the most important cause of APH is placenta previa, placental abruption. Okay. And it is complicating around 3 to 5% of pregnancy. Actually, maybe this is a slightly older source. So actually, the people who are appearing in any exam which is British or European origin, so you should try it because they make questions from this. This is one of the source of making questions related to any like morbidity which is occurring related to pregnancy. So this is this confidential inquiry for maternal and child health. This is conducted by this CMAS, okay, Center of Maternal and Child Inquiries. So so this is it. And then as I told you that you have to define, you can classify by saying that it is painful and it is painless. Okay. So painful, we told. What is vasa previa? What is vasa previa?
So vasa previa are the umbilical vessels, vessels of umbilical cord just encroaching the cervical os, covering the cervical os,
Okay.
and not covered by placenta. They
So
are
vasa,
bare.
yes, like as it's saying, vessels are presenting. Okay. So like, will it be painful or painless?
Painless,
So it will be also
I
painless.
guess.
Okay. So what about, for example, if you have a ectopic pregnancy which bleed? Will you consider it as antepartum hemorrhage? No. Okay. Because they defined it from the genital tract. Okay. So ectopic pregnancy, usually it will be occurring somewhere in the abdomen. So you will not label it as, you will label it as, just a second, I want to mute it. You will label it as like intra-abdominal bleeding. Okay. So that's it. And okay, so there are certain risk factors for placenta previa. Okay, how can you classify placenta previa? If you just focus on placenta previa, so how can we classify placenta previa? Can anyone tell?
According to other organ involvement and the myometrium involvement.
No, Zayad, that is placenta accreta, increta, percreta. Placenta previa, it is according to the, think now.
Sorry.
Now you think?
Yes.
Think now. Now think. It is according to the os. Because I am very bad at it. I always forget that if it is partially covering, the one is low-lying placenta, okay? And they do, if it is covering half of it, it is covering complete of it. So because these are the things which practically we don't bother. So these things come out of it. So any junior, if anyone want to explain about it, what is how to classify placenta previa? Maybe we will find here. Just a second.
4 types, type 1 and type 2, they are within 5 centimeter distance from cervical os, and 3 and 4 are just reaching the os, and the type 4 is completely covering the os. I don't
Yes.
remember exact distance. Some is 2.5 centimeters, some is within 5 centimeters. Four
Yes.
types major.
Yes. And the other thing which Ziad was telling, how can we tell what is increta, what is accreta, increta, percreta? Because per is crossing the viscera and coming out of maybe even involving the pelvic organs. So that is percreta. So accreta and increta, how can you tell about what is accreta and what is increta?
Accreta is just attached to myometrium, and increta is completely passing through the myometrium, engraved to
Yes.
myometrium.
Like it is going, like you can say that it is one is involving the endometrium and one is involving the myometrium, but not crossing it. Okay. So because the common pathway which ends for placenta previa and accreta is actually almost the same. Yes, the severity of the bleeding will be much more, and the people who will be involved will be definitely more. And accreta usually is there any, because there are always some queries which you have always have queries. Is this there is association between placenta previa and placenta accreta? Because this is an evidence-based question, that how many people will who have this one placenta previa will have placenta accreta and creta percreta as well. Yes, Zayad, can you highlight something about it? Or anyone, please? There is, I think there is some association in the people, like in the people who have placenta previa can there are more chances that they can have develop placenta accreta and creta percreta. Am I right?
Yes, sir. If there is a previous scar or previous history of previous cesarean section, then there are more chances of accreta or increta intraoperative finding if there is
Yes.
evidence of placenta previa.
Yes. So, like, because again, I say that the course of action is almost the same. So when we are practically dealing with placenta previa or placenta accreta and creta percreta, it is in our mind that patient will bleed a lot. Okay. But actually, these are two different things. And is this placenta accreta and creta can present as antepartum hemorrhage? I don't think so. Okay. So it will be coming in the causes of postpartum hemorrhage. However, placenta previa can start because it is in a danger area. So I think it can bleed even before delivery. Okay. So would you this is also just that nobody will be doing per vaginal examination in placenta previa. Okay. So these are few basic things, because the bleeding will be there in bleeding. If it occurs, then it will be very difficult to handle. So but for the people who are appearing in any international exam, remember one thing, that there is always a team discussion, and you are not the one to decide about when to deliver the baby and what to do. You will be just discussing. There will be a discussion between surgeon and anesthetist, and it's not primary decision by the anesthetist when and if to do the surgery. This is true even for PIH, because even in PIH, if you they are asking you about this question about the patient is having hypertension or fits, and they want to deliver the baby, it's not your decision. You can discuss about the pros and cons and what should be done at that time, but you are not the primary decision maker. So they mind this thing when you are answering such questions. Okay. So okay. So like, for example, now some practical questions, that if you have a patient of placenta previa type 1, okay, or type 2 and 3 and 4. So how will you decide between regional anesthesia versus GA? Yes, please. Anyone? I would be happy to listen from Mamuna Liaquat. Mamuna, if you are available, just speak out, because you have worked in a place where there was a lot of obstetrics. Can we give regional anesthesia in type 3, type 4?
No, sir.
Why? What is the reason for it?
There
Poor
are high
human
chances of
dynamic
bleeding
control.
during like
Uncontrolled bleeding.
Just a second. Who was talking, please? Dr. Mehnaz or Shimail? Because I didn't. Yes, Dr. Anyone, please continue. Who?
Less hemodynamic.
I'm sorry, Dr. Nadeem. You were speaking out. Unmute yourself, please. Yes, Dr. Nadeem.
Less hemodynamic control in regional.
Less hemodynamic control in regional. Okay. What else? When we are practically dealing with it, is there any relationship between uterine relaxation in GA versus regional anesthesia?
Yes, sir. GA में जो anesthetic agents use हैं वो uterine relaxation को enhance.
Yes, they will be doing more uterine relaxation. Which agent particularly will be responsible? Inhalational agents.
Inhalational. Yes.
Okay, so this is one thing. The other aspect, remember one thing, that you are anticipating, and initial hemodynamic status will be a big factor. Okay, so because even for people are, why I'm asking this question specifically, that it is not only the bleeding, the initial status, because you may have type 1, type 2, but the initial hemoglobin is very low, for example. So even in that case, you can consider about general anesthesia. You will have better control on the hemodynamics. Okay, so whenever there is a risk of bleeding, regional anesthesia is relatively contraindicated, but it's not absolute contraindication. Like, it's not related to the like, you cannot say that if for example patient definitely wants to have regional anesthesia, it's not like contraindication. It's always a relative contraindication to give regional anesthesia in a patient in which you are suspecting bleeding. Okay, because if the patient, like for example, I'm giving you another scenario, that you gave a spinal to a patient, and patient suddenly started having bleeding. Okay, because we are now I'm just trying to tell you the practical aspects. If you have given spinal and now patient is bleeding, so when will you convert to GA? Or is it indication to convert to GA immediately? If you have already given spinal, if patient started having bleeding, when would you like to intubate the patient? Would you like to intubate the patient?
Not straight away.
If the GA start dropping, so
Unfortunately, Dr. Iqra, your voice, Dr. Iqra or Mehnaz, whosoever is speaking, your voice is distorted. So if you can please try to have a better, yes, try again, please.
is dropping. Think about
I'm sorry,
Yes.
Ikra. Unfortunately, your voice is distorted. Anyone else, please?
Can you hear me now, sir?
Yes, 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 it is better now.
Okay. I'm saying that if the GCS is dropping, so we should think about converting it into general anesthesia.
Very good. So how will you now? I'm asking you a practical question again. When, like, how will you classify? You will be classify according to the hemorrhage scoring. This class 1, class 2, class 3, class 4. Okay.
Yes. Okay.
So if like the only point which I wanted to highlight, that it's not like that patient you had given spinal and unanticipated suddenly patient started bleeding and they found it to be a placenta previa. It may be a unbooked patient or patient was not diagnosed preoperatively and you ending having severe bleeding. So like you don't need to convert into GA immediately. Okay. This is the point which you endorse, what I was trying to tell you, that you will be
Sir, I
evaluating.
have a question.
Yes.
Sir, if patient have HB 9.4
Okay.
and she is placenta previa and she has history of blood reaction 2 times in a week, then
Okay.
what will be our choice for anesthesia?
Choice for anesthesia. Actually, remember one thing, blood reactions are a relative terminology. Okay. They what are the usual causes of the reactions? So there are so many advancement in it that they can give a leukodepleted blood. Okay. And they can have you have to chalk out, of course, if the patient is bleeding, because how will you decide about the transfusion triggers? Transfusion triggers you will be deciding according to the allowable blood loss. Okay. Like when would you like to transfuse? So actually in this scenario,
Sir, will
first of all, of course, the choice of anesthesia is again, that's what I'm actually, maybe I'm not explained in a very nice way. That's what I'm telling you, that choice of anesthesia always, if you are suspecting a bleeding in a patient, if you are suspecting bleeding, regional anesthesia is relatively contraindicated. But I again say it's not absolute contraindication to give spinal or epidural in a patient with bleeding. It's not absolute contraindication. You can still use epidural in a graded manner and use it as an analgesia in case, for example, if the patient bleeds a lot and then the patient conscious level is rating, then you need to convert it. And what is actually, there is another reason for regional anesthesia, because if you are expecting that the patient will be receiving massive transfusion, so there are chances of coagulopathy. Okay. This is one thing for which you are worried. And the other thing is a lethal triad, which is a part of giving massive transfusion. This is one thing. And another thing will be this one DIC. Okay. So actually, these are the people are only thinking about hemodynamics. So I am just trying to tell you that hemodynamics is not the only reason. There are so many things which you can expect, and then there is no single word answer. You will say, you will individualize. If you are having an oral discussion, you will say that you have a problem. If you are giving regional anesthesia, it will not be a good choice. And you are anticipating blood bleeding. And you are anticipating that this patient will definitely need blood transfusions. And you are expecting that this patient can need can go in problems related to blood transfusion. So in that case, if you have this reason, you can say that it's not a good choice to give epidural. Sorry, if it's not a good choice to give regional anesthesia. And among regional anesthesia, if you have to choose between spinal anesthesia versus epidural in a bleeding patient, what will you say? Which is better?
epidural.
Okay, this was a catch. in which condition there is more chances of bleeding, in epidural or spinal?
Epidural.
Okay, so if you are placing an epidural in situ, there are more chances if the patient later on goes in coagulopathy. So there will be more problems related to epidural rather than spinal. Okay, because the spinal, you are just poking it with a very small needle, and till the time this coagulopathy will occur, maybe that time is past. But if you have an epidural catheter in situ, there are more chances if a coagulopathy occur, this can create more problems versus, because again, this is the same thing which I want to highlight, that spinal anesthesia or epidural, don't think about hemodynamics alone. Think about the other things. Okay, so whenever you are, yes,
Sir, we give a GA and 2 pint of blood was transfused, and the next day the patient HB was 4.5.
okay, okay.
What is the reason?
No,
Public
you are not getting my
GA?
point. Listen, one thing. If you you know how many maximum units of blood transfusion has any one of you given in a one case? 2 units are nothing.
Sir, because we have so much fear of reaction.
No, please,
Only
Dr.
2 patients
Mehnaz,
were given.
you are telling only non-technical. This point is non-technical. So I can understand in the scenario which you are telling, I can understand the situation in a compromise low socioeconomic status. But actually, at the moment, I'm trying to tell you the theoretical thing. Okay, so theoretically, even maybe you are needing 18 units of blood transfusion. If the patient is bleeding and you are unable to control the hemodynamics, you will be giving it at that time, because at that time you have to maintain the oxygen delivery, because if there will be no
Patient was
hemoglobin,
stable,
if
vitally stable, not so much bleeding.
no, listen, so for example 4.5 hemoglobin, there may be, this may be a wrong reading, so you have to correlate with
Sir, no,
hematocrit.
sir.
I'm sorry.
At first post of day 5.5, and the second post of day 4.5.
There may be
And
some internal,
LFT is also deranged.
yes, so internal bleeding, and now this may be DIC. Okay, because when there is a DIC, internal bleeding, so this picture can come. Okay, but initially I'm just telling you that 2 units of blood transfusion in a bleeding patient is nothing. So that I just want to tell you this point.
Sir, delayed type of reactions or anything else?
Yes, if for example blood transfusion reaction, if you want to poke this question, so blood transfusion reaction, how can they present? They can present with the signs of anaphylaxis as an anaphylactic reaction. Okay, there may be signs of hemolysis. Okay, so in that case there will be there may be jaundice even. Okay, there may be this hematuria. Okay, myoglobinuria. So
Yes.
the picture can be so diverse. Okay, so blood transfusion reaction is a very broad terminology, because there is not one thing which is occurring, and there are so many ways to avoid, because because this was not our topic. I was just trying to just touch it and come back to the aspects of antepartum hemorrhage. So that's why I'm just trying to run away from your question actually, but there are so many things. There is no single word answer for single small thing. You have to rule out all the causes. There may be internal bleeding, there may be coagulopathy, there may be patient may be going in DIC, there may be transfusion reaction, and there will be combo of signs and symptoms using which you will decide. Like for example, as you are saying, if the liver functions are also deteriorating, okay, and patient hemoglobin is going down, then you will be correlating it. Then maybe, for example, there is oozing, there is drains are coming, a lot of blood is coming in the drains, and there are generalized features of DIC. Okay, so then you are saying that it is now patient is in DIC. Then you will be doing the D dimers and FDPs. So you will be confirming the diagnosis. Okay, so that's how you will be approaching it. So just coming back to our topic. So actually, antepartum hemorrhage. Someone messaged me that what do you want to discuss in antepartum hemorrhage, because everything we are dealing and we are reading about antepartum hemorrhage for a long time in our all of anesthetist. But I just wanted to give you a little bit different insight about this topic. Okay, and because we had started this book, and the topic today was this antepartum hemorrhage. So I just give you an insight that you have to think about it. I'm just trying to recap what I told you, that whenever there is bleeding, you have to see overall condition of the patient. You have to rule out what is the cause. Okay, and then it may be obstetric cause, it may be non-obstetric cause. Okay, and then there will be evaluation on the basis of history, examination, and investigations, discussion with the obstetric team. Okay, and then you will be doing some and then on the basis of this discussion, you will be deciding what you have to do. So antepartum hemorrhage, in this topic, we can cross and go to towards postpartum hemorrhage as well. But initially, you see, like they will be telling you, because before we discussed the scenario of amniotic fluid embolism. Okay, so similar picture, maternal collapse, the cause may be any of the causes which we discussed. It may be placental abruption, it may be placenta previa, or maybe patient might be having some bleeding tendency. So the history will be telling you about that thing. So whatever management you are doing, you will be assessing your journal approach will be the same, that as they are telling you that there is the patient in labor ward who bled 300 ml. Okay, she looks pale, and then you are going, and the basic approach will be everywhere. Your approach will be the same: airway, breathing, circulation, discussion with the obstetrician. You are trying to find out the cause. Okay, because there may be they may be asking you a question in the form of collapse, in which in the real time, that that is the problem when which the people, when they are discussing only one topic, and they are not able to correlate it with the other topic, because in the exam, not necessarily they are telling you, we are asking you about antepartum hemorrhage. In the same scenario, they may be expecting some information about amniotic fluid embolism, about like, for example, local anesthesia toxicity. So that's how that is the reason of not understanding the question, because if you read if you are solving any MCQ, and you are you pre-decide that this question is from antepartum hemorrhage, so, and you are not taking the patient overall, maybe you will miss. Okay, so whenever you are dealing something, always you should have a differential diagnosis in your mind, in which all the possible causes should be there, and then according to the scenario, or even this statement which I am giving you is true whether you are attempting a question or you are dealing a real-time scenario. Because in real-time scenario, you can have antepartum hemorrhage in a patient which is with labor epidural. Okay, you can have a patient with PIH having epidural, and now patient collapse. So you should be taking all three considerations in your mind. Okay, and then your resuscitation, evaluation, management, and further plan will be going according to the happenings which is occurring. So I hope you understand. You understand my point, the point which I wanted to raise. So you just have to correlate. And a number of time we are not able to answer a question because we are unable to correlate, and because we are just stuck in page number XYZ of a book. So please, whenever you are even focusing on the patient, or you are preparing any exam, make sure that your mind is open and you are thinking about all the possible causes. Okay, because today my topic is not the bleeding, so I'm just trying to make, and because all the aspects of bleeding will be the same, whether you are dealing antepartum hemorrhage, whether you are dealing postpartum hemorrhage, whether you are dealing trauma, whether you are dealing any source, the same things will be, that you are trying to conserve the blood, you are trying to replace the blood, you are activating massive transfusion protocol, you are giving 1:1:1, you are trying to have thromboelastography. Okay, you are trying to have like blood which are given all this one warmed. Okay, and you are using the concept of using cell saver. You are repeatedly changing the filters, because sometimes very small thing, like I give you example, this is a practical point I'm just sharing with you, that if you have given a blood, okay, and now you need to give platelets, you have given PRBCs, and now you are supposed to give platelets. For platelets, if it is better, you use a new filter, because whenever we are giving PRBCs, there are some debris which remain in the filter. Okay, so platelets are very sensitive. So if you want to use the same filter, you should flush it with normal saline first. This is important thing. Okay, you understand the point? That filter, they are sensitive. So if you are in a good setup, you in the exam, if you are telling, you have to replace the filter, because the pores are small, and if you don't change them, it may cause the rupture of platelets. So this is a very important point. I hope you understand. Okay, so like specifically for this case, if you are specific point about antepartum hemorrhage will be related to obstetric causes, as I told you, that there may be chances of a rupture. Patient, they might take the patient for operation theater. So, and you have to keep an eye on the fetus as well. So this will be only few things which are separate. Otherwise, the resuscitation of any bleeding patient is the same. Okay, so like other aspects which we have in an obstetric patients are related to uterine tonics, and removing all the factors which will cause uterine relaxation. Okay, so inhalational agents is one of them. Do muscle relaxant relax uterus? Yes, any resident, please. If you are using muscle relaxant, can it relax the uterus?
No.
No.
No. Okay, so it's actually it's just a funny question, because it's a uterine smooth muscle. I'm sorry. Okay, so now we will just come to the text here. They have written placenta previa, abruption, rupture, cervical or vaginal tear, uterine atony, coagulation or platelet problems. Okay, so extra questions about it, that you should be knowing what is type 1, type 2, type 3, type 4. And then you see, this is, I think, his previous pregnancy resulted in cesarean section. Is this relevant? Yes, it's in the process of placenta previa overlying the old uterine scar, increasing the risk of uterine rupture. There is also a higher incidence of placenta accreta, okay, which adheres to the surface in creta and percreta. So this was the point which actually I was just it was just slipping out of my mind. So whenever there is previous surgery or previous cesarean section and now there is placenta previa, so there are more chances that this placenta previa might result in placenta accreta in creta. Okay, so rest of the thing, and remember, don't forget, this is a pregnant patient. So whenever they are asking you a question, you are dealing with a patient with antepartum hemorrhage, you have to tell that all the physiological, pharmacological, and anatomical considerations in a pregnant patient. Should never be missed. Okay. So we will cover postpartum hemorrhage in a separate discussion, inshallah. And the things which I missed, we will cover over there, because there are like actually these are some all common things. Some they have told here, this embolization, some radiological techniques, and this balloon. There is a Bakri balloon which is being placed in the vaginal canal to stop the bleeding. Okay, so that's they have told you. Okay, so I hope I just give you a concept about this topic. Any questions before we finish? Any questions, please? Rest of the aspects of bleeding, Dr. Behnaz, I hope you understand my like point of view, that the question which you were asking, the reason of patient having low hemoglobin despite giving multiple blood transfusion, there may be multidimensional, and you cannot answer in one line. Okay, you will be overall evaluating the patient, and then remember one thing: if a patient is already was anemic and was compensated, maybe the clinical sign and symptoms will be a little masked. Like if you have a patient with compensated anemia, things will be different, because even if you have a patient with the hemoglobin of 6 with CRF, patient may be normal. The hemodynamics does not always correlate with hemoglobin. Okay. Of course, in acute hemorrhage, the hemodynamic signs will be prominent. But if you are a patient with chronic anemia, things will not be like that. Okay. So I hope you understand some of the points which I just wanted to highlight. Any question before we finish?
Thank you.
So
Role of recombinant factor 7
yes,
in
recombinant,
bleeding,
the
in
concept of
uncontrolled bleeding.
yeah, actually it is the last ditch effort. Okay, because the new concept of coagulation is through this initiation, amplification, and propagation. In that cell-based theory, there is the central role of this factor 7. So when nothing is working, if you are giving factor 7, Nova 7, this will be a last ditch effort to control the bleeding. Okay, but remember that if you are giving it, there may be incidents of embolism, because it will be initiating the coagulation cascade. Okay. Okay, Dr. Nadeem.
Thank you.
So, okay, all of you, thanks a lot, all of you, to attend the class, and inshallah, tomorrow maybe we can continue this. It was not in the queue, but I think it is better if we will discuss the remaining aspect of the obstetric hemorrhage. Some of the aspects we have already discussed, so we will just continue, and postpartum hemorrhage, and a patient with how to do an elective case with the placenta previa, and how to manage unanticipated, both of them. Okay, so we will cover the aspects related to the bleeding as well. Okay.
I have a question, sir.
Yes, Dr. Ikra.
Sir, you told that we can also give epidural in case of antepartum hemorrhage. Sir, what are the factors that support this mode of anesthesia,
Actually,
like epidural particularly?
I did not say that you should give it. I say that we can in a certain situation. Like I give you a scenario. The patient is having PIH, and now patient started having bleeding. Okay. So in that scenario, epidural can help in reducing the stress response. Okay. But always you
Right.
have to outweigh risk versus benefit. If you ask me, I will never put epidural if I have any doubt about bleeding. I will control the stress response by some other way. But actually the text things are something different. Like people in the recommendations, maybe some people will be saying in the recommendation it is written you can give a spinal if a patient is taking aspirin. But practically, I tell you something. Practically, I at least for me, I never give. if the patient is taking aspirin, I will be very hesitant to give epidural, because research may be in a different scenario, in a different setup. But if you know that you are giving a medication, you are like patient is receiving a medication which can cause bleeding. So like you can say that if you have a risk of medical legal intervention and you are worried about it, so now there are so many things which you can give in place of epidural. Like there is a erector spiny block which has less chances of bleeding, it's less invasive, you can give it. You have in setups, if you have very good analgesic medications available, you can replace it with. So why to poke a place where you don't know, where you're a stranger? Remember one thing, this central neuraxial block, you are always a stranger. You are poking the needle in the place. We are not even looking at where are you going. You are just feeling and you are going. Okay. So central
Okay.
neuraxial block always can have some problems. Okay. So it's again, Ritesh, there is no contraindication. I was just said that you can give it. It's not like contraindicated. In the exam, you can explain to them that if you want to blunt the stress response and you think that it will be another factor for bleeding, because stress response is a factor for increased bleeding. So if you are finding a way to reduce the stress response, you can use it. Okay. So I hope I answered your question.
Yes, sir. Thank you.
Okay. Thanks a lot, everybody. So tomorrow, inshallah, same time in 10:45 Pakistan time and 8:45 Saudi Arab time, we will continue our discussion. Thanks a lot, all of you, to join the discussion. Assalamu alaikum.